thanks so very much for being here. This is called, it's an idea that wonderful Candace came up with, Snacks and Facts. Usually we do the truth about plastic surgery, we do a seminar in the evening, but a lot of people find that daytime is better. So what we decided to do is to give a summary of facial rejuvenation. What I'd like is to tell everybody the truth as I see it, what happens in a consultation and how we go about helping people to look their best and feel their best. So, the truth about plastic surgery. Some of you know that we've been doing these seminars for a while. We started them for people in the beauty industry, but for reasons like, because of popular demand, we've invited the public. So what I'm going to do is show you lots of images of my own patients who have given us permission. I'm going to show you some diagrams, and I'm going to give you a summary of how we approach facial rejuvenation. So, first of all, people say to me, how is it that it's called plastic surgery? Is it because you use a lot of silicone or plastic in your work? Actually, the root, plastiko, in Greek, it's the same, mold, shape, and tailor. Sometimes people think, you know, I feel kind of vain coming in. They say, Dr. Morwood, I know you go overseas and operate and you take care of lots of difficult problems like breast cancer and hand injuries. Actually, it's normal, natural, part of human nature, a desirable, favorable part of human nature that people want to look their best. When we see someone on the street who doesn't look their best or who's not concerned about their appearance at all, we notice that there's something a little kilter. So it's normal, natural, healthy to be concerned about your appearance. Now, first of all, as I said, it's normal, natural human nature. Now, the face actually is a powerful tool of communication. The way we communicate amongst ourselves, besides the internet and cell phones, etc., is with our voice. And number two, second to the voice, is face and eyes. We convey expression, we convey what we're feeling, oftentimes meaning. And of course, some of us use our limbs more than others, and body language is very important. But number two, right after voice, is face and eyes. Here's one of the most important slides I can show today during this summary. When you come into the office for consultation and meet my wonderful staff, and by the way, everybody who has surgery meets me and spends time with me, we go about evaluating your face and facial rejuvenation and beauty analysis in terms of this triangle. Number one, on top is skin texture. That's the surface of the skin. Number two is volume, as we see in the right lower corner. Volume is very important, and we're going to talk today a lot about volume. And number three, what most people think about surgery or plastic surgery, soft tissue transposition. We're going to talk a lot about that. Sort of the older traditional way that people approach facelifts and things like that is to make an incision and pull really hard and remove skin, and that was basically what a facelift was. Well, I want to talk to you today about volumetric restoration. And what we need to do is approach these individually, these three parts. Now, on top of the foundation, this is like building a house. The foundation is essentially the craniofacial skeleton. And I'll talk more about what we mean by that. The high cheekbones, the chin, sometimes the nose, etc. But if you can keep this slide in mind, I'm going to return to this actually. When I see you for facial rejuvenation, we look at your skin texture, the surface of the skin. We look at the volume. And we also look at, is there a need for soft tissue transposition? And underneath that is the foundation. So, again, as part of our analysis, facial analysis, not only do we do the computer imaging and three-dimensional imaging, etc., we need to look at you and touch and hear what you want, and we go step by step and look at the layers, because that's very important. I just want to mention one thing. This office is not the kind of place where you get in line and everybody signs up for the same operation or the same procedure or the same high-tech laser. You get a customized approach, individual exam, consultation. You find out about what you want. And we base a lot of our analysis on your anatomy. So, the skin. Epidermis is on top of dermis. What we see is the epidermis. That can show fine lines, it can show hyperpigmentation, pigment changes, etc. But really where the business end is, that's the dermis. The dermis underneath is where the collagen is, that's where the hyaluronic acids are. Right, Oxy? Right. Excuse me, Ozzy. Epidermis on top of dermis. The dermis is where the collagen is, hyaluronic acids. And I think Ozzy's going to talk more about that later. and also Roxy will. I was mixing up Roxy and Ozzy. So the dermis is where the blood supply is, the collagen is, and that's very important. A lot of what we do with skin rejuvenation is aimed at the dermis, even though we can see the epidermis. Now, underneath the dermis is the subcutaneous tissue, that's the fatty layer. That's when we're most concerned with liposuction. We deal with that layer. Now, underneath the subcutaneous tissue, there's a fascia. That's connective tissue. It's made of collagen. It can be a thin little wispy line, or it can be tough and thick like leather, like a belt. Now, of course, underneath the fascia is the muscle. Overlying the bone is the periosteum, and then the bone. Now, we're going to talk a little bit more about the craniofacial skeleton, but for now, keep in mind that we go layer by layer when I see you in the office. Now, in general, some signs of aging everyone knows. There's skin changes, there's fat changes. What I want to emphasize, and I talk about volume, is that as we mature, we tend to lose adipose cells, fat cells, in our face and in our hands, and we gain them in our trunk. It seems like a trick that's been played on us. That's the worst practical joke you could think of. But keep that in mind. As we mature, we lose fat cells in our face and in our hands, especially the back of the hands, and we put on fat cells within our trunk. And that's men and women. A lot of it is hormonal changes and energy levels, and that's just a normal, natural part of maturing. And of course, the fascia changes, muscle changes, cartilage changes. Almost anyone in this room could see this young girl and know that it's that same person, but 50 years later, right?
Oh my God.
So after fat loss, after collagen loss, after less hyaluronic acids, right? So we know just by, it took us not even a second to know that one of those images represents an older person. However, every patient who comes in deserves a custom designed approach, because not everyone ages in the same way. Not everyone's layers respond in the same way. For example, the gal I just showed you is different from this gal transitioning to this same person 40 years later. Okay? So, one of the take-home lessons is custom designed approach. Come on in, meet my wonderful staff, sit with me. One of the first things I will say to you is, what would you like to change? Now, sometimes people say to me, well, Dr. Morwood, what do you think? I have no shortage of opinions. I'm always happy to tell you. But it's really, you know, the beauty is in the eye of the beholder. That's really key. When we talk about self-image, when we talk about what's important to you, to look your best and feel your best, that's really vital. So we start off by saying, what would you like? And we talk about, we could do the computer imaging, we go layer by layer, we can do analysis, etc. Custom designed approach. As we said, we go layer by layer: skin, subcutaneous fat, fascia, muscle, and bone. So, we're going to return to this triangle a few times, right? Skin is on top, then we have volume, soft tissue transposition, and foundation underneath. Let's talk about the skin texture. That's number one. So, for anyone who lives in California, beautiful day. We love the fresh air, we love the sun. However, the wind, especially the salt water, and the UV rays are not our friend, and they're actually disruptive to collagen. And I'm going to show you some slides later. If you look at a child's collagen layer, regardless of their race, ethnicity, regardless of the gender, collagen is thick and orderly and very well laid down. And as we're exposed to the sun and wind, the collagen layer gets much thinner and more disorderly, more melanin, etc. So, we don't have to go through this very busy slide, but take my word for it. There's chronic sun exposure, which leads to photoaging on the sun-exposed areas: face, neck, chest, hands, and arms. Now, the point is that we saw those photographs, clinical photographs. Everybody in here could pick out the older person as compared to the cohort. But what we can actually do is do mini skin biopsies on areas exposed to the sun, areas that have not been exposed to the sun, and we can actually see histologic changes. We can see changes in the collagen layer, we can see changes in the hyaluronic acid, we can see the way the collagen is laid down, etc. And so dermatologists, plastic surgeons, estheticians, we can study these things and study skin care treatments and laser and fillers, etc., to see how they affect the skin. Now, if you come on in and see, let's see, Roxy's in the other room. Probably she's either getting more food and drink ready, or she's having it herself. So if you come on in and see, Roxy or a dermatologist or myself, you're likely to be categorized, just very briefly, this is called a Fitzpatrick classification. Essentially, it's 1 through 6. Now, grade 1, those people from northern Scandinavia, fair skin, blonde or red hair, northern British Isles, they always burn, they never tan. All the way down to category 6, people with ethnicity from Africa, they never burn, they have really dark, deeply pigmented skin. And most people are somewhere in the middle, 2 through 5. But what that does is help us categorize skincare. Do you need a moisturizer? Some people have parts dry skin, some people have oily skin in other patches. But pigmentation, the amount of moisture in your skin, etc., it's very important. So Fitzpatrick classification. Now, keep in mind, as I said, the epidermis is on top of the dermis. What we're trying to do is aim at the structural elements like collagen, hyaluronic acids, right? I'm going to talk later on about filler. Let me jump ahead for a second. A lot of the fillers we use, hyaluronic acids like Juvederm, Belotera, Voluma, on and on. The main structural component is hyaluronic acid. Hyaluronic acids are in our skin. The great thing about hyaluronic acids is they retain water about 100 to 1,000 times their molecular weight, which can lead to supple, moisturized skin, right? We never want to dry out our skin, particularly around the eyes, particularly around thin skin. We want it to be supple, soft, moisturized, right? And I'll talk about that more. So the point is, there are some treatments that we can actually document that there's improvement in the collagen layer and hyaluronic acids within the skin. Things like retinoic acid, everybody's heard of retin-A, right? Some vitamin C preparations. Now, some CO2 lasers actually will result in more collagen being laid down. Some TCA peels do that too, and even some fillers, as I said. Now, as you know, we could talk about all these things, individually these things, for an hour each. But I want to, we're going to summarize today. So, skincare essentials. Number 1, avoid direct sun, right? Prevention, what's the old saying? An ounce of prevention is worth a pound of cure, or something like that. Now, avoid sun, properly cleanse. The esthetician, dermatologist, plastic surgeon can teach you how to properly cleanse without drying out your skin. Exfoliation. That's when the very top layer on top of the epidermis that's not living is allowed to shed. That's one word for it, shedding. Now, restoration. What we want to do is get the factory that makes the new baby cells that are not sun damaged to turn on and work overtime. Keep in mind, it takes about 30 days for one baby cell that has not been damaged by the sun to get to the top layer where you can see it. So sometimes I hear people say, oh, you know, Dr. Morwood, I tried skincare for 2 weeks and I don't see a difference. Well, you haven't even given your body one chance, haven't even gone through one cycle, because the cycle is about 30 days. Now just think if you went through the cycle for 6 times and you hung in there for 6 months or 12 months, or you started a good program. Fortunately, you were taught when you were a kid not to have direct sun and you took good care of your skin. It makes a difference. Moisturizing is vital, especially around the eyes, especially people with thinner skin. Now, before I leave this slide, second to avoiding sun, it's avoiding smoking. Everybody's heard of antioxidants, you know, grape pomegranate juice, etc. Well, cigarette smoke has oxidants. It's like making your tiny microvascular vessels rust. One puff of cigarette smoke has about 100,000 oxidants. So it's just simply not good. Now, here's a skin biopsy. As I said, remember we can do skin biopsies? Here's a skin biopsy of an area with kind of a thick keratin layer and not a very thick collagen layer, not a very thick factory. But after about 6 months of proper skincare and doing these exfoliations, etc., much thinner keratin layer, much thicker collagen, more orderly, etc. So it works. What I want to emphasize is these things that I'm going to show you. I like TCA peels, laser has a use, these mini peels, they're very helpful. However, this is important. Cosmetic skin resurfacing treatments do not remove extra skin or dramatically tighten loose skin. Now keep in mind the triangle. When we're refinishing the skin, that's one aspect of the pyramid. We also address volume, we also address soft tissue repositioning. And underneath there is the foundation. But this is very important to emphasize, because if someone, in my opinion, has, for example, a laser, and they think it's going to do the same thing as a facelift, you're probably going to end up in the unhappy category or dissatisfied category. And what we want is people to feel they got great value and it really worked. But a lot of that is looking at the triangle, looking at the pyramid of how we do beauty analysis and facial analysis. So this is important. Now, I want to show another slide that's just as important as this. The plastic surgeon cannot operate away wrinkles. Okay? So keep in mind what I said. Maybe the older way or traditional way of a facelift is you make an incision and you pull really hard until all the wrinkles straighten out, and you cut off the extra skin and you sew it quickly before the skin bounces back. That works for about 6 weeks to 6 months. What we want is whatever work we do to last 7 to 15 years. And that's what I tell people. How long do these treatments you do in your office, how long does plastic surgery last, cosmetic surgery? 7 to 15 years. I'm going to talk about lifting and filling. I'm going to talk about volumetric restoration. But just keep in mind that when we address that portion of the pyramid, soft tissue repositioning, it's not permanently treating the lines. It's not permanently treating the epidermis or dermis. So keep in mind the triangle, okay? Now, I want to show you an example. And by the way, I'm not minimizing the effects of laser or TCA peels, because I love to do TCA peels. Sometimes I do dermabrasion. But it has its use. It has its function. There's an expectation that we can rely on, okay? And we can't confuse those things. For example, a friend of mine lent me this CO2 laser treatment before and after. You'll see an improvement in the texture of the skin, the surface of the skin, right? Which is pretty. However, the skin has not been dramatically tightened. There's not been skin removed. A laser is a type of energy which manifests itself as heat. I want to show you an example how to understand this. Everybody's probably familiar with bacon, right? You take bacon out of the fridge, out of the package, it's soft, supple, you could almost tie a knot, right, with a slice of bacon. We heat it. Just imagine we're taking a laser and heating the bacon. 100% it shrinks. No question about it. We can get the protein and collagen bonds to change and it gets smaller. And you think, well, that's going to give me a facelift. Well, however, the bacon is brittle, right? You can snap it. And what we're trying to advocate is supple, soft, moisturized, glowing, youthful skin, right? So keep in mind the triangle. So when I talk about the individual parts of the pyramid or the triangle, my staff, Danielle, was kind enough to find me this picture to teach a lesson. When the only tool you own is a hammer, the whole world looks like a nail, right? So what we want to do is design a custom approach for you based on your anatomy, what you want, how much downtime you can take, some cost factors, etc. Expectations. Okay, so I want to talk to you about, while we're talking about skin, I want to talk to you about TCA peel. TCA, trichloroacetic acid. Some of you recognize acetic acid, trichloroacetic acid. Now, here's a picture of a young gal. What I like to do in consultation, certainly before surgery, before we do anything, I love to see pictures from prior decades. If it's a high school graduation picture or a college graduation or prior driver's licenses, whatever. Plastic surgeons love to study how the face changes over the years. So here's a gal who brought in her college graduation picture, and here she is in my office about 50 years later. So what we need to do is look at the pyramid, right? Look at her skin, look at volume, look at soft tissue repositioning. She didn't need any foundational changes. She's got a great facial structure. So following our analysis, there she is about 8 weeks later. So now there's more. My wonderful staff has warned me or told me or taught me or displayed wisdom, maybe that's a better way to say it, that not everyone who comes to these seminars is accustomed to seeing people after operations, right? So I want to show you this woman about 8 days following her procedure, okay? Because we're resurfacing and tightening and firming and, okay? So what happens with a TCA peel? There she is after her procedure, and there she is before. So what happens with the TCA peel? You need to be numbed up either in the office or in the operating room if we're going to do something else. nothing really happens for about 5 days. You might have some splotchiness. Then, for about 5 days, you exfoliate rapidly. Okay, it's like the worst sunburn you've ever had. So after those 10 days, you're left with pink skin that's smoother, has fewer fine lines, less dyspigmentation. That 6 weeks, that pink skin tends to fade within 6 weeks, and for about 6 weeks, and you can put makeup on it in the meantime. So that's TCA peel. Okay, I like it. But you've got to go through some downtime. Now I want to show you a few examples. Combination, soft tissue repositioning, TCA, and volume. Okay. Now here's a gal who's really good looking. You can see some dyspigment changes, some fine lines. She had conservative soft tissue repositioning, a little bit of volumization, and a TCA peel. Now here she is about 9 days afterwards. She's exfoliating. Get the idea? Mm-hmm. And there she is about a month later. Okay? Wow. So the point is, less dyspigmentation, fewer fine lines, more of a glow and a sheen to the skin. Okay? But you've got to go through a period of hanging out in your house or not going to a dinner party, etc. So, what about perioral lines? I see a lot of women who say, oh, you know, I've never smoked, but I have these smoker lines, or my lipstick runs into the lines, or how come my lips look cracked? There's a lot of things we do for lip lines, including revolumization. I'm going to talk about fillers. I'm going to talk a little bit about fat. Sometimes I take the TCA with a sterile, like a sponge, and I really get in there on those lines and I scrub. I call it a perioral scrub. Sometimes I do dermabrasion. We need to look at the proportion between the upper lip and the lower lip. For Caucasian Europeans, it's in general, the volume of the upper lip to the lower lip is about 1 to 2. For dark-skinned Hispanics and Africans, it's about 1 to 1. More now, of course, in Hollywood, the full lip, more balanced lip is very much in vogue. But we need to look at all these things. So when I do something like dermabrasion or TCA perioral scrub, what we're trying to do really is to take down the shoulders. If you think of the line in the lip as a little valley, and we've got 2 mountains, one on each side, we can take those down and smooth it out. Now, for an example, I want everybody to have realistic expectations. Here's a gal who's good looking, but she complained of these lip lines, and she says her lipstick runs up into lines. She never smoked, and she even went as far as to say, you know, I try to avoid straws. I don't know if that how do I know? But here she is. I want to show you her about 8 weeks after conservative revolumization and resurfacing the skin. Okay, so not perfect, but it's an improvement. So here's another gal with fewer lines. You see, she needs a little volumization, more volume, then more resurfacing. But there she is, about 2 months later. Okay. Jerica reminds me that sometimes I say starting to get the idea. I say that too much, but are you starting to get the idea? Okay, so we've talked about skin, right? I want to talk a little bit about minimally invasive treatments before we go on. So everybody's heard about Botox. I want everybody to know that Botox and Xeomin and Dysport, it's all the same active molecule. The molecule that makes the neuromotor junction relax is the same, but they're attached to a different carrier molecule. So they may have slightly different characteristics, but the action is the same. Now, I want everybody to understand clearly before our session is complete the difference between Botox and a filler, like collagen, Juvederm, Bellaterra, because these things are confused all the time, and I totally understand why, but I want everybody to understand the difference. So Botox is a muscle relaxant. So if you think of an accordion, think of the little the muscles underneath the skin of the face as an accordion, right? Like our friend Mike playing at the Pacheco Club. If the accordion is going back and forth like this, that's the muscular action. And the overlying skin, after 300, 400,000 times, gets a little wrinkle. So Botox makes the muscle relax. So there's not the accordion effect on the skin. So it's really, it started to be a medical treatment. I did this a number of years ago at Children's Hospital when I was a fellow in microsurgery for children with asymmetry. It also works, as I said, for treatment for muscle spasms. Hyperhidrosis, excess sweating can be helpful for migraines. Now, what Oh, is it about Botox that can improve people's appearance? Mostly make people feel more relaxed or look relaxed, especially around the eyes. So, there are muscles around the eyes and eyebrows that are depressors. The corrugators and the procerus and the orbicularis oculi brings the brows down. The frontalis muscle brings the brows up. So we can selectively get the depressors to relax with Botox if we know the anatomy, and I've been there thousands of times. If we know the anatomy and where the muscles are in proper use of Botox, we can let the depressors relax, and we can selectively let the elevator take over and give people a more relaxed, refreshing look, particularly in that glabella area. So, and at the lateral brow. So here's a gal, as an example, she works with the public. She came in and she said, you know, my clients and my coworkers say to me, are you tired? Are you in a bad mood? Like, what is it? And she said, I'm fine. So she came in and she got Botox just in the glabella, and there she is about 2 weeks later trying to do that same look. Okay? Now, I don't want to bore you. I just want you to know that Botox really works. Here's a gal who just felt like she had kind of tension building up in between her eyebrows. About 20 units of Botox is there. Here's a similar gal, not extreme, but she wanted a little treatment for those lines. These are the 11s. The company calls it the 1s or the 11s or the 111s. Now, and there she is afterward, about 2 weeks later. Now here's a gal who got some Botox and she wanted a little more improvement, so I used a little bit of filler. And we're going to talk about filler, because filler is a volumizer to give her a more relaxed appearance. Okay, now what about other parts besides around the eyes? I'm very careful, very judicious around the lips, because I don't like to change a man's or a woman's smile. And you know, we may have a trade-off that they may look better or have fewer lines, but I don't like the frozen look. But one place where I like to do Botox is in the neck for very early platysmal banding, and I'm going to talk about platysmoplasty later on. But for people with very early muscle bands in the neck, you know those little cords that sometimes we see underneath the chin, platysma muscle tightness, if I put some Botox into there, they will often relax and give her the effect of a mini neck lift. So, that's Botox, and it really works, and I like it. Now, we talked about skin texture, right? And we talked a little bit about Botox. We're going to talk about fillers later. Now, number 2, volume. Volume is vital. Now, Danielle, Danielle, this is her little darling. If we look at a baby, I mean, could you ask for brighter, fat-filled cheeks? As compared to someone who as we mature, we lose fat cells in our face, in our hands, and we gain fat cells in our trunk. What a practical joke. So, as we mature, we tend to lose fat cells in the face and hands and gain them in the trunk. So, volume. Let's talk about volume. This is a very, very vital issue in modern, current facial rejuvenation, volume, because it's more than just pulling really tight and cutting off skin. There's 2 big categories. There's fillers and there's fat. I use this analogy, the grape and raisin. This is California, of course. Think of a grape, right? Soft, succulent, sweet, hydrated, full, right? Round. And we put it in the sun that we're not supposed to be in, and there's volume lost and shriveling, right? Smaller. So instead of taking that raisin and like pulling the skin really tight and cutting it off, how about if we revolumize, lift and fill, right? Volumetric restoration. So there's fats and there's fillers, and I'm going to talk briefly about each. How are we doing? It's 1 o'clock. Are we okay? Yeah. Candace is. Somebody's watching the clock besides me. Okay, so fillers. There's so many fillers. We don't have time to go into all of them. Everybody remembers collagen. There's Juvederm. There's Radiesse, which is calcium-based. Almost all of the ones that I use are hyaluronic acid-based. It comes in a syringe. It's sterile. We put it in with a needle. I usually give people numbing medicine like a dental block. It works. It's a volumizer. What does it work for? It fills lines, plumps up tissue, and non-surgical facial sculpting. For example, the lateral brow the cheek, the bone and mid-face, right? All the models, if you flip through a glamour magazine, I don't care if they're men, women, black, white, Asian, whatever, high cheekbones, right? And a well-defined lateral arch. So that's the arc of beauty, regardless of where your ancestry is from, high cheekbones. So here's a gal who is good looking, but she noticed that she kind of was losing volume in her mid-face. So in the office, she got a mini lift with some revolumizing to the cheekbone areas. Okay, you get the idea? Because instead of having a vector that's sort of downward, we get a vector that's up, like more heart-shaped. Okay, get the idea? Now here's another good-looking gal, great-looking eyes. She noticed that as the years go by, she was losing her model cheekbones, the high cheekbones. So in the office, it's a syringe, right? With a needle, it's sterile. I give dental blocks, and we numb the area up, and we put little droplets deep in this particular use for filling. Okay? Starting to get the idea? Yeah. Now, on kind of a novel use, here's a gal who felt like she had some prominent lower eyelid pouches. She's not ready for surgery, but think of the, you know, the mountain and the valley? So she's got some tear troughs, some grooves. So how about instead of taking down the mountain, we fill up the groove, we fill up the valley with filler, right in the office with a block, something like Belotero. Hyaluronic acid fillers, I like to categorize them based on what's called their G value. There's a low G value, which is like almost like a liquid oil, liquidy, it's oily, or very, very thick, like a heavy voluma that goes deep, much higher G value. So here she is, concerned about her lower eyelid pouches, not ready for surgery, but she is ready for a little filler. Okay? So see how we can fill in that tear trough. So sometimes I look at Botox and fillers, there's sort of delays for surgery, or they're adjuncts, or sometimes people have surgery and then these are little touch-up procedures. Okay? So we're talking about volume, we're talking about fillers. Now what I want to talk about is the other way we do fat graft, other way we do volumization, and that's with fat. What is fat grafting? That's when we do conservative liposuction somewhere and we get fat cells that have not been damaged by the sun, usually in the deeper subcutaneous layer in the belly or the hips or the lower flanks, the love handles, if my staff will allow me to use that term. They let me say, interesting, my staff lets me say love handles for men, but they won't let me say saddlebags for women. I think there's some gender discrimination here, but it's okay. So fat grafting, volume, it's a natural filler. Stem cell, we don't say stem cell facelift around here. 1 out of 176 cells that we bring up with fat grafting is a stem cell. But more importantly, like that, more important than the stem cells, we bring up estrogen receptors. So oftentimes people will feel that their skin is being rejuvenated. And keep in mind the grape raisin principle, right? When people lose fat in the face. Now I want to show you some examples of how we volumize. Now here's a gal with really good looking facial structure, but picture a balloon where we let out a little bit of air, okay? And it allows it to kind of sag. So revolume, conservative soft tissue repositioning, okay? Get the idea? Okay, now here's a gal with a little bit more profound volume loss. What I want you to do is kind of memorize this picture, and when I show you her after picture, after conservative soft tissue repositioning and revolumization, it almost looks like she's projecting more, right? Think of the grape and raisin. Okay? So, we're talking about volume. It's a big issue in modern facial rejuvenation, okay? So another place where I really like it, and my patients really like it, some women, some men, but a lot of women tend to get what we call submalar hollowing. So this is the malar area, the cheekbones, and underneath they get a little hollow. Fat grafting into that triangle works great. And we often do that right in the office. So all these, I want you to know, all these patients are mine. They've given me permission to use their images. I'm going to show you one image out of a magazine called New Beauty that I was featured in. This woman was treated just with fillers and Botox. It's called the liquid facelift. So you can get some change. You can get some change. In the right person, if you use enough fillers and Botox,
in the right way. So far I've spoken about moving fat around when there's a loss of fat. What about when there's too much fat in certain areas? Hardly ever is there too much fat in the face. But oftentimes what happens is the fat will get redistributed to the neck, or there's too much fat in the neck. So how do we deal with that? One of the ways we deal with that is with liposuction. I'm not going to go through all the history, but suffice to say that when I do liposuction myself in the office, it's really micro liposculpture for the neck. I use very tiny cannulas, like a big needle, 3 incisions, one tiny one underneath, where most Americans have a scar already because you fell off your bike or your big brother pushed you off the stairs or you tripped on the curb or something. And one little incision where the earlobe meets each cheek. Okay, and we kind of cross-hatch, honeycomb, and that's how I do the micro liposculpture. Sometimes in the office, sometimes surgery center with blunt cannulas, so we don't cut the nerves and artery. It's a mechanical thing, so I'm molding, shaping, tailoring as we go. It's not putting in a heat probe and somebody turns on the electricity and leaves the room for 20 minutes. That's not what we do here. We manual, hands-on, micro liposculpture. So, common areas for women, submentum, and I'm going to show those axillary and pectoral folds, the waist, outer thighs. Ladies, outer thighs. I use submentum, lower flanks, love handles, okay, and in the abdomen. Now, I want to show you an example. Now, keep in mind for the triangle, right, the pyramid, here's a gal with really good skin. She has a good facial structure. She has just simply too many fat cells in the submentum. So, a tiny axis incision in the crease underneath, one axis incision where the earlobe meets the cheek on each side, and liposuction only. So we go from there to there. Now, why is this working? Because of patient selection, right? Looking at her skin, going layer by layer, looking at her muscle, which was fine, looking at her skin, which was fine. The fatty layer was in excess. Okay, custom designed approach, right? It works for guys too. Here's a guy who's a surfer. He felt like people kidded him about his baby fat. So right in the office, there you go. Here's a gal with a tiny bit of loose skin, but mostly extra fat. So before and after, okay, and another guy. Again, most Americans already have a tiny little scar in the crease underneath the chin, one where the earlobes meet the cheek. Okay, and it works well. Micro liposculpture. So here's a gal, you'll notice she's got a little bit of extra skin, right? So we talked about it, and she said, let's give it a try. I'm not ready for a neck lift. I said, I know you're not ready for a neck lift, but you'll have a little bit of extra skin afterwards. Guess what? She had a little bit of extra skin afterwards. But for her, that's fine. Here's a guy with some extra skin who said, let's just try it. I don't want a neck lift. I just want a little something in the office. As long as people know and we talk about it, we can custom design an approach, right? Now, will liposuction work for me? Look at the surrounding tissues. Of course, we want to examine your fatty layer, but we need to look at the surrounding tissues. Same in the belly. Same on the sides of the hips. Look at the surrounding tissue. We've got to look at the muscular layer. Have you been pregnant? Have you been stretched out? Does your skin have stretch marks and striae? Have you had too much sun in your life? So we look at the layer above and the layer below. Okay? So that's, if we think of the pyramid, we talked about skin, we talked about volume. Now, let's talk about soft tissue transposition. Now, most plastic surgeons, as I do, when we look at someone's face and we're considering soft tissue repositioning, we look at the face in thirds. The upper third around the eyes, the mid third is the cheeks, and the lower third of the face is the jowls and the neck. So, what about doing things in the office? Because nowadays, some people want things in the office, or we can go to the surgery center downstairs, or we can go to the hospital. I'm the chief of that division. We give you a choice. Custom designed approach. It depends on the length of the procedure and if you're healthy or not, and if you can relax, can you tolerate a needle. And we're not judgmental. It's custom designed approach. Now, what about a mini lift? What's that mean? Limited incision facial lifts. Every client needs a custom designed approach. Let me digress just very briefly. Everybody's heard about gallbladder operations, and 50 years ago, or even fewer years ago, everybody got one big long incision and 2 surgeons or 1 surgeon put it in 2 hands and took out the gallbladder. Nowadays, they at least try it with mini incisions with a laparoscope, right? Same thing in plastic surgery. We're trying to do more work through smaller incisions. When all I need is access to get in, I use magnification and fiber optic lighting to be able to get in. If I need to remove sheets of skin or a lot of skin, then I need to make longer incisions, but not everybody gets that custom designed approach. So sometimes to get to the lateral brow or mid-face, I make these little incisions in the temple. Sometimes I use just the preauricular. Sometimes I use just behind the ear. Combination approaches, sometimes a mini incision or an incision in the submentum. So let me show you some examples of mini lifts. Here's a gal who came in who has a little bit of extra skin under her neck, right in the submental area, a little bit of jowling, but she's not ready for a big facelift or anything like that. So there she is, short scar incision done in the office. Okay? Is that a teaching exemplary enough instead of saying, do you get the idea? Is that starting to learn what I mean by that? Okay, so here's a gal who has a little bit of laxity in the jowl area and in the neck, but she's not ready for a facelift. So mini incision or short scar lift done in the office. This nice lady came in from a nearby city who thought she wanted fillers, but I said, you know, by the time we go through all those syringes and pay the manufacturer for the syringes, you're going to get a shorter lasting, probably lower quality lift or effect. So she got a mini lift in the office to give that kind of change. Okay? Now here's a little bit of laxity in the neck area and in the jowl area. Mini lifting, mostly repositioning, not removing, firming, tightening. Okay, again, for the person who has a little bit of laxity, oftentimes a short scar, mini lift will do the trick. Not everyone, and not everyone wants an operation in the office. We go from there to there. Okay, here's a gal who had a vacation coming up and she just wanted kind of a brightener, kind of a little pick-me-up that she thought would last a few years. Okay, now here's a gal who has a little change in her neck. She's not ready or she doesn't need a big neck lift or facelift. But there's what she gets from a short scar approach. Now this gal needs a little more work. She needs an incision made. She needs an incision made under the chin, some approaches from around the ears to give her a more pleasant chin and neck areas. Okay? So what about other areas of the face? We talked about the upper third, middle third, lower third. That's how a plastic surgeon approaches beauty analysis and facial rejuvenation. So, brow lift. A lot of people think that they need eyelid surgery, but what they need is a little conservative elevation of the eyebrow. So here's a good-looking gal who looks kind of tired. There she is by elevating the brows. Here's a guy. I'm much more conservative in men with brow lifts because we accept in this society a more lower horizontal brow in men because it looks strong and masculine. But some guys, they just need it. Look at this guy. Big, blue, beautiful eyes being almost blocked by his brows. And we can pick that up. Now, again, I'm going through this quickly because this is a lunchtime little teaching session. Now, what about the upper lid? Oftentimes, I'll address the extra skin of the upper lid. Here's a gal who did not need a brow lift. She's got extra skin of her upper lid to give her a crease. Here's a guy who does modeling, and his booking agent said, you get more gigs if you show off more of your crease. And so we do a little modification of the crease. That's the upper lid. Now, what about the lower lid? Now, primarily, instead of addressing extra skin in the lower lid, I address the fat pouches. Here we are again talking about fat, because fat is very important in the face. So she needs a little conservative lower blepharoplasty to smooth that area out. Here's a guy with more profound lower eyelid patches, but good-looking guy, good-looking eyes, just to freshen up that area. Now, some families, here's a young guy. They have what we call a weak septum, that the fat pouches that we all have around the eyeball tend to want to push through, and we call it a pseudoherniation. And you can almost predict when these people are adolescents or even before adolescence, they'll start to show the pouches. So I do a transconjunctival approach where I go on the inside for something like that. He had no extra skin, but do you notice the difference between his pouches? So we go from there to there. No incisions on the outside, it's on the inside for someone like that. That's my favorite sculptor. Anybody here knows Rodin. Everybody knows Rodin, I bet. So, eyelid surgery. We talked about the upper lids and the lower lids. Before we exit this area, I want to talk about how important it is to consider adjacent structures. More specifically, the roof of the upper lid is the eyebrow, right? So I can't look at either in isolation. We've got to look at both. I may not affect both, but we at least have to look. For the lower eyelid, the foundation is the upper cheek, right? I may not address the upper cheek or the lower lid, but we at least have to look at that. We have to consider the adjacent structures. Now, here's a gal who thought that she just looked tired all the time, but she's got nice skin, she's got nice eyes, beautiful eyes. So we've got to do a little conservative lifting of the lateral brow, a little conservative support for the malar area, at the same time we do the eyelid surgery. Okay? So the approach where we look at the adjacent structures can be very valuable to people. Okay, now, we talked about the upper third of the face. Let's talk about the cheeks and the mid-face. Volume. Volume in the mid-face is so important. High cheekbones, right? Revolumized. You know, that sort of older traditional way where we pull the skin really tight in the cheeks and sometimes people would get a flat look. We don't want that. What we want to do is project, lift, and fill, right? So here's a gal, and this gal, surprisingly, she wanted something done in the office. She's had a little bit of volume shift. You notice that she doesn't have a lot of wrinkles, but she's had a volume shift where the volume has kind of shifted from our mid-face down to the lower face. So let's just support that. Let's just pick back up, okay? So repositioning, excuse me, repositioning and filling is oftentimes more important than removing skin. So in this view, we go from there. Look at her jowls and in her neck. Okay? So lifting, filling, volumetric rejuvenation. That's mid-face. Excuse me. So one of the important principles I want to leave you with before we exit the mid-face is volume is so important. Okay? So think of the water balloon or the air balloon. You let a little bit of water or air out of it, and it allows sagging. So it allows the gravity to take over. So we always have to think about volume, the foundation. Think of adjacent structures. Should we lift? Should we reposition? Now again, if I'm talking about volumetric restoration, should we remove? I remove some extra skin if it is extra, but mainly lift and fill, reposition and rejuvenate. Keep in mind the great braiding principle. Excuse me. So I want to show you an example of a woman where we took these factors into consideration. Instead of just pulling hard and cutting off extra skin, we revolumize, reposition, address some skin changes, okay? So we go from there. Look at the very poor support for her lower lids. See, her cheeks are coming down, and so they're allowing almost no, or providing no support for her lower lids. So we go from there to there. So those are, I've talked about, you know, trying to do things with shorter incisions, and I oftentimes do that. We oftentimes do these things in the office, but we also go to the surgery center, we also go to the hospital, and we sometimes make long incisions, right? Classic traditional facelift incision. For the person who has lots of extra skin, or we need to get access to lots of different areas and who wants rejuvenation not only in the neck but the jowls and the cheeks and the lateral brow, etc., then we make longer incisions. So we can go from there, lift, fill, remove some extra skin, reposition. We go from there to there. Now here's a gal who doesn't have tons of extra skin, but she wanted some eye rejuvenation, some cheek rejuvenation, jowl and neck. So then we make longer incisions, or sometimes more smaller incisions. But the point is that the more we need to do, typically the more incisions I have to make. But we try to, of course, hide them, disguise them, even though there will be a permanent visible scar wherever I'm making an incision. And the neck, she wanted improvement in the neck, so we go from there to there. Here's a gal who had a fair amount of extra skin in her jowl area, but we want to reposition, lift and fill. Okay? So, where are we now? Back to Rodin, and back to our facial analysis into thirds. Okay, so I think we're about rounding third base, is that okay? And Ozzy's gonna get up to bat soon, all right? So, what about the natural neck lift? I've talked a lot about the face. What about the neck? The neck is so important, foundation for a handsome man, foundation for a beautiful woman. The natural neck lift that you may have heard about, it's a system of careful analysis, evaluating appearance, anatomy, and goals with a custom designed approach. Custom designed incisions, custom designed approach. Do I need to address skin, fat? I'll talk about the muscle, etc. Remember I told you that I have people bring in photographs? Here she is after college graduation. There she is about 50 years later. Now, liposuction is not going to work for this gal, right? You're getting that idea. If I did liposuction for her, I would have a patient in the dissatisfied category. We don't want that. So skin redraping, skin repositioning, a little bit of resurfacing, a little bit of removing to get the neck smoother and crisper and cleaner. Here's a gal with nice skin, but she's got a little bit too much skin and a little bit of jowling, but she's got a great job. And this we did in the office. Now, here's a gal who needs skin reposition, skin tightened, a little bit of muscle tightening, skin resurfacing, and so we go from there to there. Here's a gal who had an important event coming up. She wanted to look good for the photographs at her daughter's wedding. A little neck tightening done in the office. Here's a gal who, you can tell that I didn't take these pictures. Her husband took these pictures, just to show you that these are not all medical pictures. We go from there to there. Here's a gal with almost no, what we call a cervical mental angle. She felt like she never really had a pretty neck. She wanted to wear necklaces and pearls and things like that. So, now, why do I show this slide? The muscle into the neck is the platysma. In the horse, many of you know, it's the shivering muscle. It runs from the mandible, you know, the big jaw of the horse, 3/4 of the way down its body, and that's how it shivers. In our species, it's kind of lost its function. It doesn't have a function except to give plastic surgeons work. So when someone has loose muscle there, I need to reposition and tighten. That's called a platysmoplasty. Oftentimes I make an incision in the crease underneath the chin, sometimes around the ear, sometimes just the back of the skin to firm up and tighten up muscle, because a crisply neck is great for guys and for girls. So some examples, there's some skin, but mostly muscle. Here's a gal with profound loose muscle. She's got some extra skin, so what does she get? Platysmoplasty with her natural neck lift. Here's a gal who has some laxity, but a lot of it's loss of volume. So revolumize, reposition the skin, tighten up the muscles. Okay? So the take-home lesson is every customer deserves a custom designed approach. Here's a gal with really nice skin. She didn't have a lot of extra skin, but she had some loose muscle, a little bit of extra fat. Okay? Sometimes people come in and they say they just want something simple in the office. They don't want a long anesthetic. They have some thyroid scars or some operation scars, and they don't mind a scar underneath. That's a direct neck lift, where I just remove the skin that we can see right there directly. So it does leave a scar, but some people scar very well, and they don't mind it, and they already have some scars from the side view, etc. So, custom designed approach. If someone just wants like a little skin excise, that's okay. Now here's a gal who has almost no change except a little extra skin, and she wanted a direct neck lift, so we go from there. Go to there. Now I'm going to show, there's Rodan again. Now I'm going to show some men because of course neck lifts and facial rejuvenation is not just for women, it's very important for men too. So Candace, what do you think about 5 more minutes? Is that okay, gang?
Perfect.
And then Ozzy's going to speak, and then there's more treats and refreshments, right? So there's his college graduation picture, and there he is 20 years later, and there he is 30 years later. So some volume restoration, some soft tissue repositioning. Okay, starting to get the idea. What we want is a natural look. I'm much more conservative in men than women, because men don't tolerate dramatic changes as much. Now here's a guy with a little bit of baby fat left in his neck. He just wanted something simple in the office. Here's a guy who came in and said he wanted a waddlectomy. I don't know where he got that. Now, here's a guy, if you look at this guy, he's a good-looking guy, but doesn't he look like he's lost some volume? And then in the after picture, he looks almost like he's projecting more, right? Revolumization, repositioning, right? Volume, right? Volume. As we mature, we tend to lose fat in our face and our hands and put it on in our trunk. Well, we can manipulate and take advantage of that. Excuse me, here's a guy almost on the other end of the spectrum, almost nothing extra except skin. So what he wanted to do is kind of show off his Adam's apple. Here's a guy with extra skin. We did him in the office, natural neck lift. Okay, so one more category, and then I think we're going to declare recess and people will get refreshments. I talked about the triangle, right? The pyramid. We've got skin, we've got volume, we've got soft tissue repositioning. What about when we go one step deeper to the craniofacial skeleton? What do I mean when we talk about the foundation? Chin, nose, cheekbones, malar bones, sometimes the ears. So here's a guy who's good looking, he has a great job, good skin, but he said, since high school, people have made fun of him because he doesn't have a chin or a neck. So what do I do for him? I make an incision inside the lower lip, one little axis incision under the chin, one little axis incision where each earlobe meets the cheek, and we can move things around. So we go from there to there.
Wow.
Okay? So he feels more confident, he looks stronger and more masculine, and all that high school teasing about no neck is just, it's just gone. And now here's a gal in a sort of a similar procedure, felt like her chin and neck were very weak, so we can bring that forward. Here's a gal, since she was young, almost no neck, or no chin. There she is healing, still healing. Here's a gal in a similar spot. So we go to the foundation. Okay? So here's a gal who wanted kind of an aggressive rhinoplasty. I said to her, you know, why don't we go easy with your rhinoplasty, with your nose, but let's look at your neck and chin a little bit too, just to balance out. So, let me just mention, we've got in-office, we've got surgery center, we've got the hospital, activities. Let me skip ahead and I want to talk to you instead of using the slides. Okay, so in general, how do you choose where you're going to have your surgery? We do things in the office. If you're healthy, if you can tolerate needles, people get oral sedation, right? Pills, but we don't put people to sleep, we don't start IVs. But it's a lot like going to the dentist. I almost cringe when I say that, but we do things in the office. Surgery center is mostly outpatient, but you can stay overnight. It's mostly for people, we start an IV, you get sedation, antibiotic, a narcotic right in the vein. The hospital, mainly for people who need a general anesthetic. You can stay overnight. Combined insurance cases with aesthetic cases can be done at the hospital. Now, what about activities? After just about everything we do, rest and take it easy for 3 days and 3 nights. On day 4, a little bit more activity, but don't get your blood pressure up. On day 11, then you slowly get back to your life. Okay? I'll be right. I very much appreciate your attention. Thank you for being here. We're going to have a little time for questions, and thanks for listening. Thank you for being here.